section at Apollo Hospital. Dr. Arun nearly have 20 years of experience in managing complex GI and liver disorders. Sir is an expert in advanced therapeutic endoscopy, IBD, liver transplantation, and pancreatic disease. Dr. Arun is active faculty at national conferences like INASL, ACG, and ARISCON. And sir is also a member of leading gastroenterology society like ISG, ESG, and so many. And I'm very happy and proud to present like passionate educator and a researcher with multiple publications and ongoing clinical studies. I welcome you, Dr. Arun, sir. And our next speaker.
Thank you, Tim Fering, who gave me an opportunity. And I also like to thank my co-speakers, Professor Dr. Vishwanathan, sir, also Dr. Varivel Kumar, sir, for being here in this forum. And today, in this wonderful evening, we are here to gather to discuss one of the most interesting and complex entity in the field of gastroenterology. It's none other than inflammatory bowel disease and various clinical scenarios. And my area of interest today, we are going to talk on 5-ASA, the dose optimization, the right dose, right time, right route, and right duration in the management of ulcerative colitis. That's the most important thing. When you're going to look into this major entity, you should know some basic pharmacodynamics as well as kinetics regarding the 5-ASA. See, usually, if you're going to categorize your ulcerative colitis, that will be categorized in three major entities based upon your various criteria, based upon your UC severity indices, along with your Tulovitz criteria, mild, moderate, and severe. So if you're going to look into the severe parameters, your ESR lab parameters will be in the higher side, along with if the patient tends to have high-grade persistent fever, tachycardia, worsening of other parameters with bowel movements more than 5 to 6 per day. So once if the patient is going to land up with severe scenario of your inflammatory bowel disease like your ulcerative colitis, when you're going to categorize mild to moderate presentation of UC, will be having predominant response with your mesalazine. But once the patient is going to check on with evidence of severe colitis, we need to subject the patient with other line of molecules rather than subjecting the patient only with mesalazine. That's number one. Apart from that, when you're going to consider the basic pharmacodynamics and kinetics, mild to moderate UC patient, there will be response almost around 50 to 70% of the population will be having a significant response. And what is this 5-ASA? We'll be having a predominantly hydrophilic small organic acid compounds. And it is predominantly going to release in your small intestine. And once it's going to get acetylated into your intestinal epithelium, what's going to happen in your intestinal epithelium as well as in liver, it's going to acetylate and it's going to form an inactive moiety, which is nothing but your N-acetylated form of your 5-ASA. And this form is going to predominantly release in your feces as well as in some of the escape molecules will be releasing in your kidneys, through your kidneys. So once if it is going to get absorbed, there are various release preparations of being there. One is time-dependent release, your pH-dependent release, your inert carrier molecules, so many things are there. But my brief area to try discuss it, it will be concentrating predominantly around 100 folds of release preparation when you're going to use your delayed release formulation like your pentas and all those things, which will be predominantly acting in your small bowel. And various compounds are there, starting from your azo compounds. What is the sulfasalazine, your balsalazine?
Arun, sorry, Arun, your slide is not moving.
No, sir, I'm not moving the slides right now, sir. I'm just giving the brief outline as of now. So once you're going to look into your azo compounds, for example, your sulfasalazine, your balsalazine, as well as ulsalazine, all those things, you need to identify the basic nature. What is a sulfasalazine? Will be in 5-ASA, which is bound to your sulfapyridine. Your balsalazine, in which your 5-ASA bound to 4-amino-benzoyl beta-aniline, and ulsalazine, in which your two molecules are bound together. So these are all the outlines you should remember. The predominant area, the release will be in the small intestine. So with this brief outline, I'll be going on with my slides right now regarding the managing the patient with IBD in ulcerative colitis, how to proceed with your mesalazine. In 1980, advent of 5-ASA moiety alone, mesalazine, which has better side effect profile, changes the landscape of treatment for UC. So as you know, the various adverse events being reported, so starting from your 2.4 milligrams to 2.4 grams to 2.4 to 4.8 grams for a duration of 6 weeks, induce complete and partial response higher than placebo management in patient with mild to moderate active UC. That's number one. Apart from that, the tolerance of the drug was excellent. Adverse reactions, limited therapy in only 2 of 48 patients receiving active medication. In this paper, if you're going to look into that, the dizziness, the fever, headache, abdominal pain, nausea, gas, muscle aches, and rarely based upon your various compounds like your balsalazine may cause your ulceration may be predisposing to diarrhea and other compounds. Apart from that, the basic things we should not forget. The 5-ASA slow release oral formulation, which is nothing but your pentasar release mesalamine, will be from your duodenum to ileum. So what is going to see, if you're going to use your mesalamine suppository, various formulations. One is by suppository, which is predominantly in the left side of colon, and proctitis, if the rectum is predominantly get involved, or else if you're going for enema, in which you have a left side of colitis, once a patient is having extensive colitis and in the predominant area of involvement in the small bowel, then you need to go for a delayed release preparation like your pentas and other molecules, and mesalamine suppository, your mesalamine enema, or apart from your various other preparations like Lialda, Dalsalazine, all these things. So your pentasar will be having a predominant event will be in region of your proximal intestine, like your mesalamine in terminal ileum as well as in jejunum. The rate of absorption will be in the predominantly higher way. Up to 59% of the drug will be passing into the colon. So the 5-ASA, the right dose, what you're going to choose, although ACG guidelines recommend 5-ASA doses up to 4.8 grams per day for the treatment of active UC, examination of real-world data indicates that 5-ASA dosing is not being maximized prior to immunosuppressive initiation. So 50% of the patients, so if you're going to look into this graph, 50% of the patients still can be treated with higher 5-ASA dose prior to stepping up for the UC treatment. So the basic outline is, see, for proctosigmoiditis, enema, your suppository and enema for your left side and your delayed release preparations for your small intestinal as well as right colonic involvement. But usually various documents, what they will mention about that, you need to look into at a dose of around 4.8 grams. OD dosage will be on the predominant significant effect rather than going for a BD dosage regimen like your 2.4 grams of per day. And your delayed release formulations will be having predominantly significant as a time dependent manner rather than when you're going for pH dependent molecules like other things. When regarding pentasar, 2 to 4 grams per day is superior to placebo at inducing and maintaining remission. When you're going to say this, 82% of higher chances of remission using a sigmoidoscopic index and 88% of higher chances of remission using a biopsy scoring system, and 82% higher chances of remission, higher chances of maintaining the remission will be with your pentasar of 2 to 4 grams per day, which has been proven in this paper. And increased rates of endoscopic as well as histological remission with pentasar 4 grams per day versus placebo. So the histological, see, always when you're going to target a patient with inflammatory bowel disease, the clinical response is very important. Your endoscopic healing is important. The histological remission has to be important. And along with that, when you're going to consider always at a right dose, 4 grams per day, when you're going to give the placebo, you'll always having a potential response. The increased rates of endoscopy. So in this paper, it will be clearly proven almost around 0.18 and 0.12, which showed the difference. So that's proven, that shows clear evidence that the significant rate of response with your endoscopic as well as histological remission with your pentasar 4 grams per day when compared to your placebo. And once daily dose of 4 grams prolonged release mesalazine is an effective and easy to use treatment. That's what been proven. See, complete remission in this paper, if you're going to see the complete remission at week 8 as well as the endoscopic remission at week 8 and mucosal healing at week 8, the mucosal healing and the improvement in UCDI, the ulcerative colitis, disease activity indices. So all these parameters at week 8 will be having when in case. So when you're going to use your full pentasar at a rate of around 4 grams per day, when compared to your so once daily dosage will be having a significant potential response rather than giving your divided dose regimen. So high dose of 5-ASA led to reduced recurrence. That's what been significantly proven in this paper. If you're going to use almost around more than 4 grams per day of molecule, so which means the rate of recurrences is going to come down in managing a patient with IBD-UC. And if in this paper, dose escalation of 5-ASA reduces and or normalizes fecal calprotectin levels in patient with quiescent UC and increased levels of fecal calprotectin. So what I've been looking at, once the fecal calprotectin less than 50, less than 100 and less than 200. So if you're going to look into that, the dose escalation reduces or normalizes your fecal calprotectin with quiescent UC and increased levels of fecal calprotectin being significantly absorbed. And proportion of patients in remission after 1 year appreciably higher in the group treated with 4.8 grams per day. So if you are going to use a high dose regimen like 4.8 grams when compared to your 2.4, the remission rate will be significantly higher when compared to your 2.8, 2.4 grams that's been proven in this paper. And is it, what's the right time? The right time as I already been discussed, based upon the disease severity, mild to moderate and moderate to severe based upon your various indices. And always you should remember in Crohn's disease, once a patient, usually the rate of response, moderate to severity, moderate to severe conditions, the Crohn's, the rate of response along with isolated mesalazine will not be significant potential and no major role with your mesalazine alone, but always in the background of mild to moderate UC, if you're going to treat a patient with proctitis, use the patient with topical mesalamine along with topical steroids or oral mesalamine. That's one regimen for induction. And maintenance, either give oral mesalamine with topical mesalamine. And left-sided UC, you need to use the patient with topical mesalamine plus or minus steroids. Topical steroids are oral, or you can go for your budesonide MMX coated. That you can consider in left-sided UC for inducing, for induction. Apart from that, in maintenance, you can consider with oral mesalamine plus or minus your topical mesalamine. In extensive UC, you can, in the background of mild to moderate disease, you can consider topical mesalamine in combination with your oral mesalamine. Systemic steroids or beclomethasone can be tried, but in maintenance, you can add your oral mesalamine with topical mesalamine. But once the patient is going for your moderate to severe conditions, always the steroids and biologics will be our more potential role and no major role for at the point to manage a patient with mesalazine. Apart from that, physicians need to decide whether to administer 5-ASA as an induction or maintenance therapy depending on the indications. As you all know, the induction therapy based upon the indication like moderately active when the patient is going to have previous use of corticosteroids, or if there is any rectal therapy at the time of relapse, or multiple medications for UC at the time of relapse, or in background of maintenance therapy, the shorter duration of disease remission or previous use of corticosteroids or partial remission even after the maximum dose is used, you can consider. And the right route will be, as we've already been mentioned, three main type of formulation: suppository, your suspensions, your foams, and major advantage over oral formulation, the lower number of physiological obstacles to overcome for the drug to reach its target. And topical preparations result in better responses as well as in earlier improvement in mild to moderate distal UC. So always mild to moderate distal, so more of topical preparations will be more advantageous when compared to your oral formulations. And once a patient is having predominantly right chronic involvement, we can go for oral formulations at that point of time. And mesalazine suppositories induces more prompt as well as superior clinical, your sigmoidoscopic as well as histological improvement in the background of UC. So if you're going to look into your UC only for ulcerative proctitis, so mesalazine, if you're going to use your suppository, the rate of response will be significantly higher when compared to your tablets alone. So suppository will be having more prompt as well as superior response for proctitis. That has been proven in this paper. And your suppository lead to clinical as well as endoscopic remission. So in endoscopic remission rate in rectum, when you're going to see when compared to your placebo in this paper, the endoscopic remission will be having a significantly higher, as well as your clinical remission rate also will be significantly higher when you're going to use your suppository for evidence of proctitis. And combine oral and enema treatment with pentasa is superior to oral therapy alone in patients with extensive to mild to moderate UC. So always you need to use, as I already discussed, once a patient is going for mild to moderate presentation, at the point of time, oral as well as enema, you need to consider patient with moderate severity of UC when you're going to address in the background of the bowel movements, if it is going to be more than 3 to 4 episodes per day. And always combination result in improvement rates almost around 89% in 4 weeks and 86% at 8 weeks compared with your 62% and 68% in your placebo group. And in the combination is going to result in remission rate almost around 44 and 4 weeks and 64 at 8 weeks in moderate severity. At that point, you can consider this. Always the combination therapy will be having a significant potential response in tackling a patient with mild to moderate UC rather than giving a isolated monotherapy. And apart from that, your combined oral as well as topical 5-ASA therapy is superior over your oral 5-ASA alone in the induction of remission of mild to moderate UC. So that's what already been mentioned in this. The combined therapy always shown to be having a significant potential role. So 35% higher chances to achieve remission with versus monotherapy with 5-ASA. So for relapse of disease activity in poison UC, combination of oral as well as topical mesalazine and high dose of oral mesalazine will show a significant potential better outcome. So when you're going to use a combined therapy, so with your oral as well as topical, it shows a significant potential response when compared to your topical therapy alone and when compared to your other line of molecules. So in this paper, the combination of mesalazine with your topical mesalazine alone were both ranked as most efficacious related to your placebo to achieve your endoscopic remission. So that's what we mentioned. So always combination therapy, mild to moderate, is better more consideration rather than alone. Efficacy of intermittent topical 5-ASA is superior to oral therapy in terms of preventing relapse of quiescent use. In this paper, when you're going to use your 5-ASA, yes, topical preparation always is superior to oral in preventing a quiescent UC, in relapse of your quiescent UC. That shows a significant potential response. And the right duration, what is going to consider? Always you need to give at a rate of almost around 4 grams, 4.8 grams per day. When you're going to maintain at least at a duration of almost 6 weeks, that shows evidence that the patient is going to have a significant endoscopic mucosal as well as your quality of life is going to get significantly improved at 6 weeks when compared to your 3 weeks. That has been proven in this paper. Patients with moderately active disease have a greater improvement in your scores like after treatment than patients with mildly active disease. In this paper, if you're going to see the treatment associated with significant improvements in all the domains at 3 as well as in 6 weeks when compared, when you're going to use for the prolonged duration, rate of response will be always escalated. And Pentasa, 4 grams per day, significant advantages over placebo for induction of clinical remission as well as in this paper. 4 grams per day will definitely have a significant advantageous effect over placebo for induction of clinical remission as well as in endpoints at around 8 weeks of duration. And 2 to 4 grams per day, suppose when Pentasa more effective than placebo, and you drag it as mesalazine at maintaining remission at up to 12 months of therapy. Pentasa 1.5 to 4 grams per day versus placebo for maintenance of remission at 12 months. And in this paper, so always if you want to maintain, you need to give a slightly higher dose. That's very safe rather than giving at the lower dose. And longer duration lead to significant improvement your clinical presentation, and more than 6 months of therapy, almost around 80% of the significant reduction in the rate of recurrence will be plotted and proven in multiple papers when you're going to look into that. So always longer duration of 5-ASA treatment led to 81% of significant reduction in risk of recurrence. Apart from how are you going to optimize your 5-ASA? As I already discussed, various release formulations are being there, and 5-ASA optimization, the maximum dose, if it is going to be more than 4 grams per day, is always better than 2 grams per day at inducing clinical response or complete remission. Combination will be having significant potential response rather than giving as a monotherapy, and extended duration will be having a significant. So these 3 things. So the treat to target, when you're going to look, the most important thing is maximum dose, combination therapy, and extended duration of treatment. That's 3 things to be more considered when you're going to use your 5-ASA preparations in the managing a patient with ulcerative colitis. So this is the basic decision. How are you going to obtain the basic outline model? So for induction as well as for maintenance. So once if for induction, what you're going to do, you need to start at low dose and mild to moderate UC. Okay, you can start at low dose, but once if the patient attains remission, then you can have a significant maintenance with the standard dose of ASA. But optimize your dose of ASA plus or minus steroids. If the patient not going to respond, then treatment with prednisolone along with biologics online therapy based upon the clinical response. Apart from in maintenance, the treatment will be standard 5-ASA, and you need to look for whether the patient been optimized. If the patient is showing significant response, then you need to give the community remission therapy, or else if the patient doesn't show a response, then you need to go for relapse therapy. Relapse and therapy escalation has to be considered. And optimizing 5-ASA therapy, use of combined oral plus rectal therapy as well as the maximum oral doses as being clinical benefits and support wider adoption in clinical practice. So in this paper, the combined oral plus rectal therapy always will be having significant potential benefits rather than giving oral doses alone. And use of oral greater than 2 grams per day plus topical preparation over oral monotherapy. This has already been discussed. The same thing, eco guidelines based upon that. So combination based therapy, oral 5-ASA combined with topical versus oral 5-ASA alone. So combination will be having a significant potential role when compared to your monotherapy. So in this paper, use of topical 5-ASA for maintenance of remission in patient with distal UC. ECO guidelines was the clinical remission versus placebo with the topical 5-ASA, your endoscopic remission. All these things will be having a significant potential response with your topical preparation rather than with your placebo alone. So when you're going to look into your Colitic Foundation guidelines for inducing remission in UC, as I already been discussed, you need to give a higher dose, prolonged duration, and always once daily preparation, more consideration, along with mild to moderate will be having significant potential response. But once the patient is going for severe, consider the patient either with steroids or biologics, intravenous or oral, depends upon the presentation, and always dose escalation to the maximum dose, and during maintenance we can have a tapering regimen, but monotherapy usually not much of consideration, but maintenance of remission in UC, long-term therapy always been more consideration. In the background of mild to moderate UC, the dose that was used for induction of remission should be continued for initial maintenance of remission, and 5-ASM maintenance dose reduction can be considered in patient with UC having mild clinical course with complete mucus leaking. So for patients with moderate to severe UC who requires corticosteroids for induction of remission, 5-ASA should be continued for maintenance. So three major important indicators: long
the stochastic, which is currently available, which has got shown a very good response even in pancolitis, much more in left-sided colitis.
Thank you, sir. And doctors, if you want to have any more questions, please unmute yourself and you can ask Dr. Arun, Dr. Vadivel, and Dr. MSV. If there is any.
Vadivel sir, there is a simple discussion since this is an open forum. And see, actually, sir, there are three major things I would like to ask with you all, sir. See, we are coming across, we have been using budesonide, we have been using prednisolone. And as already we mentioned, when you are using prednisolone, we need to give at a rate of 40 milligrams initial week, followed by we need to taper for a duration of 2 months, that's okay. But there are some guidelines in which whatever mentioned, hit the patient hard with 40 milligrams for 1 month and then slowly taper. That is number one question to discuss, sir. Number two is, in acute severe ulcerative colitis, when we are using a patient with hydrocortisone on the initial phase, most of some patients we are coming across with potassium lowering even, because there is a lot of mineralocorticoid based effects will be there. So at that point of juncture, whether we are using methylprednisolone to tackle a patient with ulcerative colitis, that's one good guidance. But when we are going to use methylprednisolone, how does the dose titration will be happening? Will we have significant potential? Because most of the papers they have been mentioning to combat the effect of hyperkalemia, it's better to give methylprednisolone, in which low mineralocorticoid potency will be there when you are going to use the methylprednisolone. Number three, an acute severe UC, based upon our Oxford criteria, when you are going to use with hydrocortisone, in the background, once a patient is not going to respond, or whether we have any trial of experience with cyclosporine, or we will subject the patient with directly biologics.
Okay, so coming on to point one. So our Indian patients, the body mass index is much less, the physics is different. Okay? So what we look out for is predominantly Western studies. Their body physics is entirely different. So the drug distribution is different in these individuals. The drug metabolism is different. So
Yes.
we need to customize things for our own individual. Okay. For an Indian scenario, average 60 kg individual, on a 40 milligram dose of steroids, we can very well taper it at the end of 2 weeks. So it need not be prolonged to more than at least a month as such. If you are facing any difficulty in tapering down steroids, then we need to switch over to the other drug, either in the form of that means
That's other thing.
it's an indication that these people are steroid resistant, maybe at times. Then we need to look out for other molecules like small molecules like DAC inhibitors, or we need to step them up to biological. Basically. So this is about the point one. The point two is regarding the use of steroids. Okay. So if it is going to be severe acute colitis in any form, it's always prudent to use methylprednisolone. It has got an instant action and a prolonged efficacy in these individuals, because our target in these individuals are to attain a remission or stop the bleed within the first 3 days. So the moment we start methylprednisolone, which has got a very good efficacy, bringing down the symptom, predominantly the bleed part. So we'll be more worried about the controlling the bleed. So that will be achieved within 3 days with methylprednisolone. But hydrocortisone has got a shorter duration of life. So that dose has to be repeated. It has to be repeated every 6 hours at least. So that is steroids. So you can't be putting them on load and load of steroids. Basically. So the ideal option would be to go for methylprednisolone, which has got a very good potency, but to the top of the frequent dosing of the hydrocortisone part. I think what is the third one?
The third one will be whether we are having any experience with cyclosporine when we are tapering, if the patient not responding to steroids.
Yes.
In
the patient has been So the problem is when to take them off steroids or switch it over to a steroid sparing agent when they are steroid dependent. That is the thing. So cyclosporine, considering the drug profile, the adverse events in the form of renal failure, hypertension, all these things are more with cyclosporine. So we have got a much better drug in the form of azathioprine or even methotrexate do work in these individuals as a steroid sparing agent rather than the cyclosporine, or even a tacrolimus does much better job than a cyclosporine. Because even in the recent transplant studies, they started using more and more of tacrolimus rather than cyclosporine. Or even you can go for a mycophenolate mofetil. So cyclosporine is kept at the last, even for in a patient with a transplant. So we need to predominantly use azathioprine first as a first drug for steroid sparing agent, followed by methotrexate if the patient is tolerating it well, followed by you can go for a mycophenolate mofetil or a tacrolimus, and cyclosporine will be the last, which we may not be in need of cyclosporine as such. If all these things are not going to work, we can very well switch these individuals to either a JAK inhibitors or put them on a biological. They're much safer compared to the adverse events of these steroid sparing agents, which can be used for a longer term.
So I have one more thing to Dr. Vishwanathan sir. So Vishwanathan sir here. Vishwanathan sir?
Yes. Tell me.
Yeah, sir. So actually, I came across with young babies, just 1 year old, which was happened almost 1 year before, diagnosed with evidence of bleeding PR, in which you are proceeding with colonoscopic surveillance. It showed evidence of active UC, pancreatitis, just 1 year old, male baby. So we initially initiated the baby with mesalazine topical as well as oral at a lower dose regimen. We haven't considered, but I didn't use the baby on any steroids since the baby is just 1 year. And moreover, it's not very severe colitis. It's going to be moderate intensity of UC. So I have given with oral as well as topical. And I have assessed the baby's response after 3 months of therapy. And moreover, the baby had significant clinical response. And over a period of for the past 1 year, I did twice colonoscopic surveillance, which showed a reasonable improvement. But even though the mucosal healing is still minimal inflammatory cascade is going on, but the response is reasonably better. So in that scenario, 1 year old baby, what is your opinion, sir? We need to give steroids along with that, or
no? Very good question. Very good. Before I go down, even IBD in that age group is very important. Allergic proctocolitis. The most common presentation is the cow's milk protein allergy. One has to absolutely be certain that allergic proctocolitis. Though the cases I mentioned, I always make sure allergic proctocolitis. A very common way of cow's milk protein allergy presenting in pediatrics, particularly in infants, is that's the way. And because I've seen actually 5 months old child severe allergic colitis, secondary to introduction of cow's milk very early, introduction of soya milk, where we have a cross-reactive. So we have to make sure we are dealing with allergic colitis. We have to make sure that we exclude the milk and dairy containing products for a period of 3 to 4 weeks, then reassess them for a response. And there's an improvement and there's a recurrence of the symptoms upon challenging again, then we have to make sure this is we are allergically what we are dealing with. If you are absolutely certain, if you are absolutely tried to rule out allergic colitis, then we go down the treatment of making sure other diseases are being ruled out. Then we go in the direction of IBD. Having said that, to be honest, is very few cases I had to start steroids on a baby of less than 1 year. Most often, I ended up having to. I have got what, for example, I got 300 cases of allergic colitis in a child less than 1 year, and against 2 or 3 cases of IBD very early. So IBD less than 1 year, particularly. So I think if we are going in the direction is fine, but again, very few of them need steroids. And if they need steroids, we have to make sure we are not dealing with a monogenic IBD also. That's another important, a subgroup of patients who has got monogenic IBD. We have to rule out genetics also. We have to rule out immune deficiency states because many of these primary immune deficiency can present in that age group. That's another important. I've seen HIV presenting the colitis, honestly. So all those
No.
things has to be ruled out. Yes, thank you.
Yes. And we have worked up with all the basic mutations along with the immunodeficiency workup. All those things been done. Everything that's been negative. And moreover,
Yeah.
alleged panel, the baby was on complete breast milk apart from the other weaning protocol diet, not on any artificial milk products or any cow's milk. But only thing is the calprotectin tends to be the persistently high with clinical significant point of bleeding PR and other things. And the endoscopic findings more in favor of multiple abscess lesions. So that's why we've been considering in terms of that. And now the baby is doing reasonably good, sir. Thank you.
Okay, thank you.
So it was an intense discussion, and I would like to express my heartfelt thanks to all of you for attending this valuable meeting. And I particularly want to thank our esteemed speakers, Dr. Arun, Dr. Vadivel sir, and Dr. M.S. Vishwanathan sir, for their insightful presentation. And their expertise and knowledge have undoubtedly enriched our discussions. So we wish to have such a productive and engaging meetings in future also. So thank you so much, and have a nice night.
Thank you. Thank you very much.
Thank you,
sir.
Thank you. Thank you, Baba. Thank you, Arun and Dr. Vadivel. Thank you.
Thank you, sir.
Okay.